One of the basic conditions that we see in pediatric adolescent gynecology are issues surrounding puberty, if it's too early, if it's too late. So the basic evaluation starts with an understanding of when is too early, which is standardly defined as a period before age 8, or when is too late, which is a little bit more complex, either no period and no secondary sexual characteristic developments by age 13, or no period with secondary sexual characteristics at 15. Early puberty most commonly is simply the activation of the normal pubertal axis, the hypothalamic pituitary ovarian axis, early. The issue with early puberty is the development. Congenital outflow tract abnormalities, specifically those that cause obstruction, often present with pain. Pain can be a really common symptom in adolescence. Typically, when we are working with an adolescent with painful periods, the condition is not a complex genital tract abnormality, but more likely to be premenstrual syndrome or primary dysmenorrhea. When we recognize that period pain is actually starting toward the middle or end of the menstrual cycle and lasting beyond the menstrual cycle, we suspect that a potential genital tract abnormality may be the cause. The next step is working with the patient on setting up imaging that they're comfortable with. Very often the first step is a transabdominal ultrasound, and then being prepared to have a complex discussion on what surgical management looks like. When discussing genital tract abnormalities with families, it's important to do so with the comprehensive gynecologic lifespan. The discussion is not simply, this is the surgical treatment, this is what to expect postoperatively, but what to expect in the future related to periods, related to pain, and specifically related to fertility. In these conditions, it's very helpful to have a combined approach with behavioral health. Oftentimes, especially if there is an impact on fertility, and having emotional support both for the patient and their family is important. When a surgical treatment is needed, typically a laparoscopic approach, minimally invasive approach, is what's preferred. This allows adolescents to spend significantly less time in the hospital, less time in recovery, hopefully more time getting back to their normal activities such as school, social activities, sports. My initial interest in focusing on pediatric adolescent gynecology just came from a love of complex gynecology. But over the years, especially because I am also an adult obstetrician gynecologist, I can really see the connection between having a healthy reproductive life during your childhood and adolescent years and being a healthy adult. Being able to work with an adolescent on understanding the importance of reducing the chance of infections and the impact that has on fertility, for example, is very valuable. Helping an adolescent understand what a normal healthy period is and what that should look like for her whole menstrual life is important.